We're going live.
Hi, folks. I think some people have joined us. I can't see you, but I think people can see me. If you can see and hear me, can someone send a message? Hi, Dave. How are you?
Good.
We used to have a moderator, and the moderator left, so I think I am moderating now. Thanks, everyone, for confirming that you can see and hear us. I guess on that note, we'll get started on time, so I'll start playing this video. Please let me know if you can't see or hear that.
My name is Ethan. I'm one of the next presenters on our presentation, CAMS and Crisis Care, Theory, Research, and Practice.
Oh, I'm sorry, Dave, would you mind muting your microphone? I think we were having some echo issues.
Yep. Sorry about that.
No problem.
I'm trying to figure out how to do that.
Mine is right on the top, next to the title.
First up is going to be Dr. Dave Jobs presenting on our theoretical portion. So I'll pass it off to him now.
Good morning. I am delighted to be here to talk to you about the collaborative assessment and management of suicidality, otherwise referred to as CAMS. In our discussion today on the Fairfax County's use of Crisis Stabilization Centers, I'm going to give you a bit of an overview of the theory and development of CAMS, so you have a sense of what this intervention is about. CAMS is a therapeutic framework that is focused on the use of empathy, collaboration, honesty, and being suicide focused. So in standard CAMS, pre-pandemically, post-pandemically, hopefully, we sit next to the patient in this collaborative style with the patient's permission to go through a thoughtful consideration of who, what, where, when, why does this particular patient consider suicide. In the pandemic times, we do this in a parallel version that I'll describe a little bit as we go forward. But in the model, the framework thinks of suicide as the bullseye of our care, independent of the diagnosis. We build a strong therapeutic alliance to increase patient motivation, and we do something very special in CAMS, which is to have the patient identify those problems and issues that compel them to consider suicide, which we call suicidal drivers. So CAMS is both a philosophy of care in terms of being empathic. We never finger wag, we never invalidate the patient's experience of being suicidal. We don't shame, we don't blame. That doesn't mean that we endorse suicide as a coping strategy, but we are collaborative in all of our dealings with the client. We're honest and transparent as we use a therapeutic framework from beginning, middle to end of CAMS. What guides the CAMS intervention is the suicide status form, which functions as a roadmap of sorts. In the first session, that copy of the SSF that's completed in the patient's hand, where the clinician takes over looking at risk and warning signs to develop ideally an outpatient treatment plan, but that requires the stabilization plan and the identification of suicidal drivers. We also collect information about mental status, a DSM or ICD diagnosis, overall symptom distress, and then your case notes. So the SSF documentation is a multi-purpose assessment, treatment planning, and tracking tool that thoroughly documents your care of the case. After the initial session, there are interim versions where we track the ongoing risk. There's a quick reassessment of what we call the SSF core assessment, and then you focus on the stabilization plan and the treatment of drivers. Every CAMS interim session ends with a treatment plan update, and then your additional documentation as well. When criteria are met for outcome disposition resolution, there's a final outcome version of the SSF. We get one more check in the core assessment. We look at the outcome disposition and our final documentation that's HIPAA compliant and completes a full medical record. So in other words, we collaborate with the patient. We use the SSF in this fashion to guide the assessment and treatment planning process. to focus our treatment on the problems that we call drivers that make the patient consider suicide in the first place. So this is a closer look. The first page completed in the patient's hand. There are various quantitative and qualitative ratings that we work our way through. Reasons for living, reasons for dying. And then the clinician gathers these risk and warning signs as well. The treatment plan is supposed to keep somebody out of the hospital if at all possible, but to do that, our first problem is your self-harm potential. We secure lethal means, we create problem-solving skill sets, we think about how to decrease the patient's isolation and potential barriers to care. In this case, this patient's two drivers are self-hatred and not trusting other people. Now, moving access to lethal means is very critical to stabilize the environment. We know this from our Army study where we had one soldier who had a stash of pills. And securing these pills in the course of her initial CAMS care was a significant sort of good faith step in the right direction, that she was committed to working on an outpatient basis and not being tempted by her stash of medications. So beyond stability, treating drivers, you can do whatever treatments that you know to do to treat the problem drivers. So it might be evidence-based interventions, it could be psychodynamic-based interventions, anything that you know treats drivers but is potentially worked into the therapeutic framework. In interim tracking sessions, we're looking at, again, the core SSF at the start of every session. We're going to sort of fortify or tweak the stabilization plan if needed. And at the end of all those sessions, we readdress the treatment plan and potentially sharpen or focus the drivers more specifically. All SSF documentation, especially the stabilization plan, is given to the patient as a copy, or they take pictures on their phone, and we fill out the rest of the medical record documentation, mental status, diagnosis, overall judgment of risk, and case notes. Towards the end of CAMS, if criteria are met for resolution, which is 3 consecutive sessions of an overall risk of a 1 or a 2, that they're managing their thoughts and feelings, there's been no suicidal behaviors. If we meet those criteria, we're approaching resolution of CAMS. And in that approach, we're looking at what makes a life worth living and trying to get to a focus away from suicide towards those things that make life worthwhile, that help develop plans, goals, and hope for the future, and a life with purpose and meaning. When these criteria are met, an overall risk of 1 or 2, and they're managing the thoughts and feelings for 3 consecutive sessions, we then get to the final outcome disposition version of the SSF, one more core assessment. You look at the outcome disposition plans going forward, and then your final documentation for the completion of the medical record. We know CAMS is supported by a lot of evidence. There are now 5 randomized controlled trials, which is the gold standard of what impacts, in this case, a patient in a causal way. So 5 robust RCTs. And we also have 8 correlational studies that have shown CAMS to be very effective in a variety of settings. At the Fairfax Community Service Board, this community mental health agency, they've been using a version of the suicide status form and CAMS for a number of years, and you'll hear more about that in our presentation. We have 3 ongoing cases, one taking patients out of inpatient care after they made a suicide attempt, very high-risk group. This is the aftercare focus study. Another study that is being conducted in Bielefeld, Germany, by Miriam Santel and her team. This is an inpatient use of CAMS. And finally, there's a 3rd randomized controlled trial that's ongoing, now moved into a telehealth modality that Colin Depp is leading at the San Diego VA in California. In pandemic times, we've moved the use of the SSF in a parallel fashion so that you could use Zoom. The clinician will complete the SSF. The patient will complete their copy of the SSF and have this copy for their own use. We're working together in a collaborative fashion, even though it's in telehealth, and the clinician's copy becomes the medical record. We also are working with Microsoft Office and have a fillable PDF version of this that can then be interfaced with electronic health records to make sure that the data gets into the health records in electronic form. But still, writing out on the SSF is very important, and we want to retain that approach because we know that writing is different than typing. Better encoding, better retrieval, better memory. So we try to mimic that even in pandemic times. So overall, the evidence base for CAMS is robust. There's well over 75 publications, the 5 RCTs, one meta-analysis showing that CAMS as a therapeutic assessment, among other kinds of assessments, that actually completing the SSF is a therapeutic experience for the patient. We also know that CAMS decreases overall symptom distress, depression, and hopelessness, but its cardinal finding is that it quickly reduces suicidal ideation in 6 to 8 sessions. That is the biggest population of people in our country. 12 million Americans each year have serious suicidal thoughts in the adult population. So reducing suicidal ideation quickly is important. If we reduce ideation upstream, there's going to be fewer attempts and ultimately completions downstream. So we're really excited that CAMS does address the largest population of suicidal people. We also know CAMS that increases hope and clinical retention to care. And there's evidence that CAMS reduces emergency department visits, and patients like it more than treatment as usual, and clinicians like it and find more confidence in their care by using CAMS. CAMS works better with less severe patients, but there is some data that it is comparable to DBT in terms of reducing self-harm and attempt behaviors. More research is needed for that. And we know that CAMS is relatively easy to learn, with adherence quickly obtained with your first patient in 4 sessions. So that's my approach to thinking about working with suicidal risk. I'm excited to be a part of this panel, and hopefully you find this useful as you hear about the other applications of CAMS within this particular population. Thanks so much for joining us. Take care.
Hi there, my name is Ethan. I'm a postgraduate research assistant in the Suicide Prevention Lab at Catholic University in Washington, D.C., under the direction of Dr. Dave Jobs, who you just heard from. So I'll be presenting some research today that connects CAMS to crisis stabilization, and I'm excited to be here. First, some acknowledgements. I, of course, want to thank my project team, Dr. Jobs, my co-authors, Victoria and Amy, who helped make this research possible. Likewise, for the leadership board at Fairfax County's Community Service Board, who allowed us to gather some data from Woodburn Place, which you see on the bottom right there. I'd also, of course, like to thank the mighty data entry team of 5 undergrads from our lab who really helped make this work happen. My presentation's laid out just like every other empirical paper. We'll start with the introduction, the method. We'll look at what we learned from our research, and then most importantly, connect it to what clinicians can really implement and use in their work. So of course, as you just heard from Dr. Jobs, this is the start of the CAMS SSF, and it's our primary source of data for our study here. Each of these 6 orange arrows is one of the metrics that we're taking. So of course, these measurements are being taken at the initial session of CAMS, as well as the outcome session of CAMS. And these 5 SSF core constructs are psychological pain, stress, agitation, hopelessness, and self-hate. As you know, we're also asking patients to rate their own overall risk of suicide as they perceive it. Each of these metrics, of course, is from 1 to 5. Now, historically and traditionally, patients experiencing suicidal crisis are immediately routed to psychiatric inpatient units. We know that these are very restrictive. We also know that they're very expensive. Crisis Stabilization Centers, on the other hand, historically less expensive. They also typically serve lower SES groups. Something that really sets them apart is that they're residentially oriented. And within a public health model of suicide prevention, they offer important, comprehensive, and community-oriented mental health care that is really unique, I think, to this level of care. Now, of course, the community-oriented part of this is that important because it brings in a broad spectrum of clinicians in crisis stabilization with a range of educational backgrounds, different training competencies, and also different comfortability levels in different modalities. And what's interesting about that is that CAMS, as Dr. Jobs explained, it offers a non-denominational, as we call it, treatment framework. So clinicians are really free to the extent they can with any particular patient to bring in, the treatment modality, whether that be CBT, DBT, motivational interviewing, to work with a a patient that really best suits that patient. You're not tied to any one particular modality. And I think that makes CAMS appropriately suited for use in crisis stabilization settings where we're seeing the spectrum of clinicians. Now, some other research that connects CAMS to crisis stabilization. There's some research on change in SSF core construct severity ratings that's been conducted across several populations like college students, inpatient, outpatient, and military populations. Previous work identified, this is with college students, an index of SSF core construct ratings as a moderator of between session change throughout treatment. And that's important. It also connects with other related CAMS work that relates to crisis stabilization. There was an article by our colleague, Amy Brausch, who examined the use of CAMS with adolescents in crisis stabilization in the United States. A similar study was done with adults in crisis stabilization in Norway. However, as you can see, there's a clear window in the research here looking for use of CAMS in crisis stabilization center with adults in the United States. And so identifying this window, and seeing this archival data set that we had, we identified 4 hypotheses. The first, that the severity ratings would statistically significantly decrease from initial to outcome assessment. Next, that the drop-offs in each one of those ratings would be correlated with each other. Third, that the SSF core construct ratings at the initial time point would reliably predict change in suicide risk from initial to outcome assessment. And lastly, that the SSF core construct ratings would predict outcome suicide risk following treatment. And so these data were gathered in aggregate from an archival electronic medical record from Woodburn Place in Fairfax. It's a state-facilitated 16-bed crisis stabilization program. And the folks there had been using the CAMS treatment framework for use with patients experiencing suicidal crisis since 2017. And so our data were gathered between 2017 and early 2019 when our study began. Our average participant, or patient, to give you an idea, is about a 38-year-old white, non-Hispanic male with non-severe level mental illness in care for about 2 weeks in crisis stabilization. Of course, all of our patients were experiencing suicidal crisis at the time of admission. Our results. So what we're seeing here, I think the easiest way to see this is looking right at the chart. Our blue columns are the initial ratings, orange for the outcome ratings, and each one of those brackets is representing a significant drop-off in those ratings, which is exactly what we're looking for. Each one of these core constructs is related to suicidality, and so we want those to drop off through treatment. Next, what we're seeing is that those brackets in that chart are essentially all related to each other. They're all correlated with one another, which is helpful information because we would want all of those things to be coming down. That's important to know. Next, for our third and fourth hypotheses, number 3, initial readings of SSF core construct severity ratings predicted change in suicide risk level from initial to outcome. And likewise, they also predicted outcome suicide risk. And why that's important is because when we have a particular patient who comes in who's maybe matching a particular profile, symptom constellation, something like that, we can gather information on them and predict perhaps what their treatment may look like as far as change in suicide risk level over treatment. Likewise, we can also make some guesses about what their suicide risk level will be by the time they are leaving treatment. And so this research, it's very basic. It's nearly preclinical, but it's one small part of a growing foundation of work, which is why we're here at this conference. This work with further research could suggest that clinicians are addressing emotional trends that underlie suicidal crises and are important. It should be targeted within treatment. As I said, if we have a particular patient who's coming in that's matching, let's say all 5s straight up and down the SSF, we know certain things about what their treatment might look like as far as risk reduction and what they're going to come out of that treatment looking like in a suicidal crisis sense. Now, we of course knew this about other populations, but this is some of, like I said, an early body of work that's looking at it within SMI heavy groups and likewise within crisis stabilization. It's also possible that pursuing more stable traits like self-hate could potentially yield greater clinical change in treatment as opposed to more volatile traits like agitation, which we see more fluctuation in overtreatment. Naturally, there's always room for limitations and future directions. So starting on the right, we were unfortunately limited by the COVID-19 pandemic. We had to stop our data entry a bit early, and that yielded a smaller sample size than we had hoped. We'd also look for in a potential prospective study to have a more consistent data set, but that's just the nature of working with archival data. On the left side, psychological science, one of the future directions that we're really interested in is to what extent would it benefit patients to target these emotional constellations based on their presenting symptoms? To what extent can we make that useful and helpful for clinicians and for the patients themselves? Likewise, how can CAMS be best implemented in crisis stabilization settings to ensure success for the clinical unit, for the clinicians, and for the patients? And my next presenter, Orit Paytan, is going to be telling you more about that. So I'll pass it over to her now.
Hi, everybody. My name is Orit Paytan. I'm a licensed clinical social worker. In this presentation, I will review how CAMS is being used in a crisis residential setting called crisis care, the challenges crisis care face in implementation of CAMS, and the solutions we found to address those challenges. I worked in crisis care for 10 years, first as a clinician and now as a supervisor. In 2011, I got introduced to CAMS and immediately became a fan. It was the first time I worked with a suicide assessment and management tool that identifies and addresses the specific drivers of suicidality of the individual and allows to develop a suicide-focused treatment plan. During the past 9 years, I've seen how this tool became the gold standard of assessment and management of suicidality in crisis care. It took many hours of work, passion, and dedication to create a system that uses CAMS to save life. So let's talk a little bit about who we are. Crisis Care is located in Annandale, Virginia, which is near Washington, D.C. The program has 16 beds. We mostly serve individuals without insurance or with Medicaid. About 30% of our clients are homeless. The average length of stay is 7 to 10 days. We serve approximately 500 individuals per year. And we offer very structured programs that include 6 groups per day, daily individual sessions, psychiatric evaluation and medication management, and discharge planning. This is how crisis care look like. Very homey place that look like home and less like a residential place. So how do we address suicidality? So before a client is being admitted to crisis care, we generally already know that she or he reported suicidal ideations. Now, once the client is in the house in crisis care, enters the program, a licensed or a licensed eligible clinician sits with the client for the intake assessment. If the client reports SI, or we already know that he reported SI, the clinician introduces CAMS to the client, and if the client is willing, the clinician collaborates with the client to complete the initial assessment and to include it in the service plan. During the time the client stays in crisis care, several interventions that are specific to suicidality are being offered. The first one is Crisis Stabilization Plan, or a safety plan, which is non-negotiable. Once the client reports SI, really encourage them and push them to create a safety plan. If the client refuses, that will create some challenges when they're supposed to get discharged. The other one is skills building. So a lot of our groups in crisis care are around skills building, and some of those skills include DBT skills, CBT skills that can help in managing the daily life. And also we offer hope books, virtual hope books, and coping cards that we're going to talk about that in a second. Due to the short stay of most clients, usually CAMS interim is not being completed with the client. However, with highly suicidal clients and with clients who stay in crisis care longer, we do collaborate with them to complete this follow-up assessment. At discharge, clients who reported SI are completing also SI outcome, so we can see where they are and there was any change or in there's any improvement of how they're feeling. So what you see here in this slide, those are the examples of some of the suicide-specific interventions that we offer. In the middle, you see the virtual hope box. This is an app that was developed by the military that is really offer a lot of different tools. A lot of time, clients, they don't have their safety plan with them in the back of their pocket, but they always have their phone with them. So we really encourage them to download this app and use it while they're in crisis care, so they can get used to the features that it encourage. You all actually can download this app to your phones and play with it to see what it offers. Also, you see an actual hope box that you see it on the, I think it's the right side of the slide, where we have a group where clients create a box and decorate it and just put inside all kinds of encouraging statements, maybe pictures of loved ones, maybe things that makes them feel good. So once they are discharging, they can take it with them. The other side, you see coping examples of coping cards. So coping cards are those just small cards, like small index cards, where the clients write things that are specific to their situation that can give them hope or reframe a negative thought or remind them what to do when there is a crisis. In the specifics that you see here is coping skills when I'm feeling suicidal, and the other one is reasons why I'm not a failure, where the clients really think about, some evidence that shows the opposite. So there are many challenges we face in implementing CAMS in crisis care. The first challenge is differences in the skill level of different clinicians. Many clinicians are very invested in adhering to the CAMS philosophy, and they use CAMS exactly the way they were trained, while others may not be so invested. And then there is time constraints. Many times the shifts are short-staffed and are very busy, and clinicians can find it challenging to meet with clients and complete CAMS. And then it's a very hectic environment, and staff may need to attend to another crisis, and the CAMS is unable to be prioritized that day. And then it's staff turnover. This is challenging because it is necessary to train new clinicians every few months. And lastly, some clinicians hold limiting beliefs about suicidality and suicide assessment, such as a belief that CAMS is triggering the client, or a belief that clients with borderline personality disorder are suicidal just to get attention, or a belief that there is nothing we can offer to a client who is chronically suicidal. Those beliefs are standing in the way of collaborating with suicidal clients to complete CAMS. So here are some solutions we found over the years to really address those challenges. So the first one is ongoing trainings. We offer 1-hour training for new clinicians to orient them to CAMS And we also encourage clinicians to take a 3 hours training that is offered through Fairfax County to expand their knowledge of CAMS. And then we have Community of Practice. Community of Practice is once a month meeting that is open to crisis care clinicians and other clinicians in Fairfax County CSP in which CAMS cases are being staffed. This is an opportunity for staff to ask questions about a particular case they find challenging. Then we have clinical discussions, which are 30-minute discussions that take place 3 times per week in crisis care, at the beginning of the day shift. During those discussions, all clients who would benefit from CAMS and a crisis stabilization plan are being identified. This is helpful for the clinicians who work on that day to plan their day and ensure they complete a CAMS or crisis stabilization plan with the client. And there is assessment tool. One of the clinicians in crisis care developed assessment tool that address those limiting beliefs and really help clinicians to identify what are some of the beliefs that they hold. And then supervision. In supervision, we address any questions they have about CAMS and also limiting beliefs. And lastly, there is shift change. Every morning and night, the shift leader reads updates to the next shift about each individual that is in the house. The shift change contains information about risk issues and identifies clients who would benefit from CAMS and need to complete a crisis stabilization plan. Thank you so much for listening.
I'm not sure if our moderator is going to jump in. There may have been one question that we missed. I was trying to get back to that. Carol had asked, I think halfway through my presentation, can you talk to anticipated changes to suicidality and or suicide rates related to the impact of the COVID-19 pandemic? And if there are efforts to apply CAMS in different settings to reduce deaths by suicide. Dave, that's probably a question best for you.
Yeah, so the jury's still out. The data from a SAMHSA survey of 5,700 Americans in June was that suicide ideation was up in 11% of the sample, especially among young people, especially among people of color. And so the ideation is up and the level of overall distress is up. So depression, anxiety, substance abuse in that survey is 40% of the sample of, I think, about 5,700 people. So we know that in Belgium and Australia, their completion rates are down since COVID-19. So ideation doesn't necessarily equate to more completions, but the data, I think, is worrisome. And so on the CAMS Care website, which is the business side of all this, we posted in March a series of adaptations for using CAMS in telehealth and a fast track paper that was published in the Journal of Psychotherapy Integration in June about how we're managing to try to adapt the intervention for the current pandemic.
Hi, everyone. So we had a couple more questions come in. So for teams who currently are not utilizing CAMS, what would be your advice to get a team, like where can they start?
Orit might have some practical considerations, but I mean, if they want to go to the CAMS Care website, which is the training website, as a group, they can get a rate and get all the training in CAMS now is online since COVID-19. So we have a menu of different kinds of options, so people can read the book and copy the forms and just self-starters can do it that way. There's a 3-hour online course. There's virtual role play training that we do. And then consultation, like I do with Orit's group in Fairfax. But we have other consultants that can do that. So I I don't mean to be commercial about this, but the CAMS-care website, if you Google it, you'll find it has a lot of different training options for people that are interested.
That's very helpful. We'll for sure share that link, whether it be here or on our Slack page. Another question, and I'm not sure if this one was answered, but can you talk about the anticipated changes to suicidality or suicide rates related to the impact of COVID-19? And if there are efforts to apply CAMS in different settings to reduce death by suicide?
I think I answered that. There's concern about increased ideation. We don't know yet about deaths. We have seen actually telehealth be remarkably successful, and a lot of patients prefer it. We've also seen healthcare systems that are suspending asking about suicide risk or screening for suicide risk because of fear that distal intervention is going to be more difficult, and that's not okay. So I'm on a task force that has basically created a recommendation that will be promulgated by the National Action Alliance, that there are safe ways of doing remote assessment, even asynchronously, and that you don't have to be in the same room to tackle a patient who's suicidal. This can be orchestrated through a thoughtful way of doing informed consent and different approaches in this document that's being pushed out.
Which is very well needed right now. Dr. Jobs and Orit, Ethan, what state do you all operate out of?
Orit, you want to pipe up?
Yeah, Virginia.
Virginia. And are you both?
I'm in DC, and I have a small practice in DC, but my university is in DC as well.
I'm also in Virginia, halfway between Dr. Jobs and Orit. I'm not a clinician, though.
Another question we had was, can you speak a little more about the supporting data that took place in the US? How did it compare to Denmark and Norway?
The Danish and Norway, where they were pure straight up community mental health agency kinds of settings, those countries have very robust public systems. In Denmark, they have 8 regions, and each region has multiple centers that are just for suicide risk. Any person, any Danish citizen can walk in and get treatment in evidence-based care. The U.S. studies are mostly out of Harborview Hospital, which is a big urban medical center. Our first randomized controlled trial was done there. Very similar to the population that Orit was describing, 40% homeless, severe mental illness, heavy substance abuse kinds of issues. And we had very good effects on using CAMS with that population. And that data is now being replicated in the current randomized controlled trial.
All right. And Orit, have you experienced in practice any challenges in applying CAMS, or perhaps barriers, whether it be at the state level, at the organizational level?
So no barriers as far as the state level. There was some thought in Fairfax County that only licensed clinicians and licensed eligible clinicians are gonna be able to use CAMS with clients, but we really pushed that that's not gonna be the case, which was successful, and now every clinician can do that. Really the barriers are how do you get clinicians to buy into actually using CAMS? Because there's so many beliefs. I mean, we have so many clinicians that think that, or at least we used to. Now we don't have it so much. When we just started using CAMS in crisis care, clinicians thought that it's gonna trigger clients, that they're going to become more suicidal, and we really had to do a lot of education around that. And I'm talking about years. I mean, I started using CAMS in 2011 in crisis care. Ethan said that we started in 2017 to use CAMS, but really we started before that. It's just that 2017 we started to collect data. But now it's a well-oiled machine. Everybody are being trained. There is an expectation that they're going to use it with one exception that we say, if the client doesn't want or doesn't think that that's going to be helpful, we're not pushing it. We said, okay, we're not gonna do it.
Dr. Jobs, you're on mute.
I was just going to confirm what Orit was saying, that this has been a labor of love and sort of a grassroots evolution over a number of years. It's a bit of a paradigm shift. A lot of us grew up in a world, I certainly did, where a suicidal person goes to the hospital. And simple. That's what you do with a suicidal person. And yet what the more recent data shows is that these very brief stays are significantly associated with increased risk post-discharge. And basically all that really happens in most contemporary inpatient settings is medication. There's some groups, but patients don't really like them. And this is not soapboxing. There's data on this. There's NAMI data that shows that really contemporary inpatient care needs to become much more suicide focused. And we do have inpatient versions of CAMS as well. But I really look to the Fairfax effort as being sort of an evolution of success, where we changed a whole culture in thinking about, you can work effectively with suicidal people and skip the hospitalization step many times. And that's oftentimes in the patient's best interest.
And to echo you, Dr. Jobs, that's why with Crisis Residential Association, it's one of our taglines, an alternative to hospitalization, the least restrictive choice that would be possible for the client, in order for the client to be able to replicate what they're experiencing with the clinician. Often in inpatient setting, it's very restrictive. It's medication only, not a lot of skill teaching and being able to apply it to all areas of life. Can you, Dr. Jobs or Ethan, can you speak a little bit more? It looks like CAMS is doing some more research and growing in the areas of perhaps group application.
Yeah, I can speak to that. We have mixed results in VA. There's been a fair amount of use in a network of hospitals in Tennessee and Kentucky. We think it's effective, but the one trial was sort of, was not decisive. So we're trying to get funding for a randomized controlled trial to really test it. It seems like it should work. We think of it as CAMS on steroids, but really we need to rigorously study to make sure it's effective and doesn't cause harm.
And it looks like we have time just for one last question. Do we currently know if CAMS is being utilized in all regions of the U.S.?
Oh God, no.
Just asking.
We'd love to see that happen, but really what people get is hospitalization and medication.
Okay.
So, the evidence base speaks to dialectical behavior therapy, 2 forms of cognitive therapy in CAMS, but people rarely use these interventions. What you see us presenting here is actually the exception rather than the rule.
Okay. Do we know what states are utilizing CAMS? Is that info out there?
On the CAMS Care website, again, I hate saying this, but there's a clinician locator. And so we do a lot of trainings around the country at the community mental health agency level and then at the individual level. So if people are looking for referrals, they can go to that website and locate people that are trained in CAMS.
And I know we posted that link in the chat. Well, we are up on time. Thank you so much, Dr. Jobs, Ethan, and Orit. And if you all have any further questions for any of our presenters, please feel free to reach out to them in a private message through our console.
Thanks
Bye,
so much.
everyone.
Thank you. Thanks, Ethan. Thanks, Orit.
Of course. Thanks, folks.
Thank you. Thank you all. Bye-bye.